Hi, I'm Dr. Celine Gelgich.
And I'm Dr. Tori Miller.
Welcome to Breaking the Rules.
On Breaking the Rules, we talk about all things OCD.
Obsessive compulsive disorder, OCD, impacts up to 1 to 2% of the population. We are here to provide not just education, but to inspire clinicians, families, and people who are impacted by OCD to be able to access the treatment they need in order to get better.
Catch us every fortnight, wherever you get your podcasts. Tell us about the intersection, because you mentioned before that you have a very sort of person-centered approach and that you're certainly working with the whole person, and sometimes that includes co-occurring things like OCD. Love to hear experience about, how OCD shows up for you and your clients.
Absolutely. I think it's hard to disentangle OCD sometimes with a lot of eating disorder clients, particularly ARFID, but also a lot of anorexia nervosa clients. There's also a third layer there of autism, which tends to kind of go with OCD, autism, and eating disorders very, very nicely. And I think often when I see OCD and eating disorders, when I map them out, I'm not necessarily seeing them as the primary disorder that starts. Often they're not the first thing to show up in somebody's story. They're almost like the maladaptive coping systems that show up in response to a very dysregulated central nervous system that's compounded from trauma early on or other elements. So they work very similarly. They look different, but they've got the same purpose. They're designed to have the same maladaptive coping and protection. And you hear them sort of when you meet them, you sort of hear some clients say to me, well, I engage in counting calories because it's my OCD. I need that element of checking because it makes me feel better, because obviously it's a temporary relief, isn't it? It's like my whole body, my central nervous system is overloaded, and then I engage in either an OCD behavior or an eating disorder behavior, whether it's counting calories, checking the door 5 times, rather it's serving that same mechanistic purpose. So it's this temporary relief. It's like unresolved pain underneath that these two behaviors now side by side can do really nicely to shut that off temporarily.
Do you often see OCD kind of establishing itself to protect eating disorder behavior?
Absolutely. I see sometimes, not always, but sometimes what I'll see is that eating disorder, we kind of go like whatever started first in someone's story, whether that's trauma, whether that's whatever shows up first, eating disorder then presents. And then the OCD comes along as this grey, almost camouflage disguised sister on top of that to go, shh, guess what? Nobody in society can really handle eating disorders yet because it's very stereotyped, and that's a very naughty thing to do. So use me because I'm great. People seem to think OCD is just like this medical issue, and it's okay. It's normalized to have OCD. Yes. So it does, and it shows up in those.
True.
Use these words,
it's such
right?
a bugger.
When you, it really does. Like, I don't want to eat my dinner. Tell them it's because it's sensory based. Tell them it's because you've already checked 3 times. You're not allowed to eat 4. OCD, okay?
Yes.
Tell them you can't be a certain body size because it's just outside of the rules of OCD. So they can kind of manifest it in a way. It works perfectly. And they get away with it. They really do. They use the language of OCD very well. And in many circumstances, they've got this layer of manipulation that comes on top of that. And combined together, they can really outsmart, whether it's a healthcare professional, a
it's
parent.
It's a powerhouse.
I'll say.
It's the dynamic duo.
Absolutely. They're like a little powerhouse going on together that
couple.
whisper to each other, and then they've got the same goal.
Yeah. And you're so right, because I'm picturing sort of the family system or people at school, and if someone said, I don't want to eat that because I'll get fat, they'll the reaction versus I'm just worried that the ham is off. So and how one would kind of engender kind of, I think, scorn, and the other empathy.
Yes,
that's right.
And also would be like, oh, I get it, fair enough. If you're not sure that the ham's off, oh, look, maybe don't eat it just to be safe. Yeah, it's better if you don't.
Totally.
Like total collusion.
Absolutely. Because it plays on that contamination.
Yeah, exactly. Or I'm not sure if my mum washed her hands while making this, so I'm not going to eat it.
Yeah.
That's right. It's good, isn't it? Like, it's like, oh, no, I didn't eat the sandwich today at school because my mum didn't wash her hands. And I'm really worried about the contamination of the ham. So like, oh, I don't want to be dealing with a tummy bug today. Nope.
Yeah.
Yes.
No, thank you. Yeah.
Well, then, because I'm curious about, I mean, maybe it doesn't matter. Maybe it doesn't matter, but also about the reverse where OCD might actually be the origin story. And then, because I do think we do see sometimes.
In some instances, yeah.
We see clients, and that's probably why they end up with us being treated for OCD rather than perhaps an eating disorder service, is because it seems like the origin is OCD, and then as a consequence of major restriction because they can't bring themselves to eat, or they can't go to the supermarket and select vegetables and fruits and things, or, you know, just that severe restriction comes in and their desire actually isn't thinness, for example. It's sort of more of a death anxiety. I don't want to get sick. I don't want to be harmed. That they end up underweight and in starvation syndrome.
And sometimes it's an avoidance as well. Like, for example, if there's a 3-hour hand washing and toileting ritual, I will then restrict food and fluid. So that then not have to go to the toilet. So I don't have to wash my hands and then have a 3-hour shower afterwards.
Yeah, exactly. So to get on with my day, I don't eat or drink so that I don't have to use the toilet at school.
Yeah.
Yes.
Yeah.
Or anywhere.
I would say that
and
too.
so then an eating disorder kind of develops secondarily to the OCD. Yeah. I suppose my question on that is, if we're going to tackle this, how do we decide as clinicians where to start?
Yeah, great question.
How long's a
I
piece
think
of
it
string?
goes back to I guess it's everyone individually, isn't it? Again, I think it's our job really then to navigate this story, you know, going back to that earlier, you know, reasoning of where did this begin? You know, really using our old skills of train analysis and going, hang on, I can hear the symptoms. The symptoms look like OCD. The symptoms look like eating disorder. We've got to map out together where this started. What was the perpetuating? What was the precipitating? You know, have a look at it that way. Like, did it start from OCD? Did it start from that real fear of contamination or germs or whatever it was? And generally that was where it began. And it led into eating disorder kind of pathology, because now I'm terrified to eat this and my body naturally lost all this weight. Because the refusal and the avoidance is not necessarily eating disorder pathology, it's OCD pathology, but it's got the same outcome. So, you know, it's having the same impact on me physiologically and psychologically. So it's sort of about navigating which one started and also which one's predominating. That's a really interesting question too, because it doesn't really matter sometimes which way it started. It's almost like which one now is dominating, because it could have been the OCD that started. It could have been the eating disorder that started, but that doesn't necessarily mean either is stronger.
Yes.
So we've got to look at
about where's the greatest functional impact. And looking at that first.
That's right.
And I guess I also wonder also about where the client is prepared to start.
Yeah. Absolutely.
Where you have buy-in.
Yeah.
Absolutely. Yes, which again comes back to that trust,
that you'd probably get greater buy-in starting with OCD if it starts.
Well, that would be my prediction too. Yeah. What about you, Alissa?
Same. I think sometimes it's gentler. It's much more softer to kind of go in with the OCD lens and sort of present it to them in that way. Like almost give them a really good understanding. People love to be educated. I think there's this myth that youth don't want to be educated. They love to be educated, but they want to know it in a way that really maps onto them, that really like hits them. And so, you know, if you can really give them this gorgeous diagrammatic or verbal or both even better way of understanding the relationship between OCD and eating disorders, but also what it's serving, how it's purposing, but also then going to what it's doing to them, perhaps negatively, whether that's psychologically, socially, physiologically. And then let's create the story from there. So say, hey, what really makes sense to you? Can you see it this way? Can you see how this is where she was born? This is where she was born. And they're kind of working together at the moment. This one seems to be pushing her a little bit harder. But what makes sense to you to work on? Because I'm happy to do all of that, but we want to make it at a pace and a style that really suits you. And usually what you find in that layer of education is they look at you and go, wow, oh gosh, I didn't really realize that was happening or why they're here. You know, but I think it's probably better if we start with this, like the OCD, because I can see that really triggers me. you know, when it comes to thinking about food. And so I think if we work on that, then it's going to make it easier for me then to like tackle all the food and weight side of stuff.
Yes.
Yeah.
Couple of things that came to mind, if I may be so bold to jump in. Okay, because I'm starting to imagine clients that I work with. Okay, and I just want to absorb all your expertise while we're together. So one of the things that I notice is that when there's that intersection of eating disorder and OCD, when we're, say, doing ERP and we're doing, say, an exposure menu, and when we get close to the symptoms, the compulsions, the triggers that are sort of both sort of OCD and eating disorder, in my experience, probably more rigidity and more resistance than perhaps I see in other spaces. And part of what I think that's about, or what I've experienced, is a blend of both. I mean, you know, with OCD, we know that there's a lot of ego dystonic. A lot of people saying, this doesn't make a lot of sense. I know it's got functional impact, like, et cetera, et cetera. But what I tend to find is that when we get closer to it, eating disorder, that clients are far more sort of fused with their thoughts. They actually believe. There's a lot more sort of egosyntonic thinking and belief systems, and that is harder to tackle using exclusively sort of ERP as we normally would. And I tend to find that it can be a sticking point. And I'm curious about how you would navigate those tricky moments.
Absolutely. I think you've hit on a very stalled sort of place that a lot of psychologists can find themselves when they're working with eating disorders. I think ERP is gorgeous when we're thinking of OCD traditionally on its own. It doesn't. It works fundamentally. It's one of those therapies where I love there's such a structure that sort of sees that progress and those little milestones tick off, and they're so excited to come back in and tell you about it. When we're thinking of eating disorders, it still can work. It can work nicely in that hierarchy structure. However, if you haven't gone underneath and you haven't, again, tackled that real trauma sort of, I guess, educational side of it, they're very rigid in those thoughts and beliefs because they're not even aware sometimes of why they're holding on to these beliefs. You know, they don't even understand sometimes why it is they want to be not even thin, sick thin, like unwell. Why am I wanting to hold on to this sick role? What does it serve me? And sometimes stepping too quickly into the ERP, sort of for them, they're not at a place yet where they're ready to do it. They're still very resistant. They're still holding on to a lot of confirmatory bias, and that sort of ability to engage in it's just not there. So the work's a bit harder, eating disorder-wise. We've got to do more work in sort of saying, this is what you're dealing with. This is why it's so hard for you. Let's talk about those rigid thoughts. Let's talk about the reasons you do not want to even gain a single kilo. Like, what is that about? Before we kind of step them more into the behavioural lane, because we want them to win. We want them to reach those goals the same as you would with traditional OCD. But I think that there's a difference in the severity of the rigidity that they're presenting in those thoughts. It's the rationale for it's different, because somebody that's coming in with, say, contamination of germs, you know, we sit in front of them and go, they almost know. They know that this is like very outrageously, you know, pathological. They understand that washing their hands 500 times is something that's giving them harm, that's causing them harm. They know that others aren't doing this. And so they're very happy for us to help them. They want to get help with that. Whereas anorexia nervosa, for example, there's less of that. They're sitting in front of you. They may know that they're underweight or not. It depends. But either way, that sort of ability for us to persuade them in sort of like the pathological side of it's a lot harder. There's a lot more work to do. So I think that's just a bit of the difference I see when I'm doing the ERP work. I kind of leave it towards the end, if that makes sense. And when I'm up to the end of, we've got all that education now. We're there. We're both on the same page. We want this. Are you ready? And look, it might take me longer, though, to be honest. The ERP for someone with anorexia nervosa might be spread out a lot longer. Those steps, say if you're using 6 steps, for example, that might be stretched out a lot longer. The goals and, you know, setting them together might be a lot smaller. So we might need to do 2 or 3 ERPs, right? And they've got different serving their purposes. So that's sort of just a slight difference between them.
Yes.
In that foundation, for me, it just seems like laying the foundations to do the work, right? Something that I often find helpful, I'm curious to hear your thoughts about whether or not, I mean, clients say it's helpful, but
Let's go with that.
A lot of the schema, like the mode work, kind of calling them out and bringing in some of those beautiful schema techniques, I find incredibly helpful in those moments to kind of build the insight and encourage clients to see the pattern and what's going on in order to then start to shift and come on side. Is that something that what are some of your more practical approaches in those moments?
Absolutely. I'm biased, and schema therapy is my love language. Schema therapy would be my all-time favorite therapy. I think it's the godfather. And so for any presentation, whether it's OCD, whether it's eating disorders, whether it's complex trauma, BPD, I start with schema.
Yeah, great.
So that's the work that I'm starting with. We're always identifying the vulnerable child. We're looking at the coping modes. And I think we've spoken a lot today about, OCD and eating disorders as the coping modes. I kind of express it to them in that way, have a look at what they're serving. We'll also, look at the punitive parent and discuss the punitive parent as well, and obviously conceptualize that. I think, using, externalization as well really helps less in terms of for anorexia, though the eating disorders talking, because they're often very triggered by that, but often trying to work into a way of maybe it's not necessarily the eating disorder talking to you, but is there something that resonates with you? Like when you feel the urge to purge, when you feel the urge to kind of like step into those rigid sort of pathological behaviors, is there something that we can verbalize for you that makes sense? So we do a lot of externalization, less around the eating disorder talking, but giving it a name that means something to them. And so I think the foundations like you're talking about from a schema lens are just gorgeous. They're rich. There's sort of the language that they really resonate with and they want to hear. They can hear it. They like a lot of the work that goes on with it, the videos and the worksheets and just things that really makes them feel comfortable and educated with what they're dealing with. And I think then we can step into the more behavioural things.
Yeah, amazing.
Thinking maybe we could talk about ARFID.
Yeah, absolutely.
Maybe we could start from just you telling us about what ARFID is, and then we can sort of weave it into the OCD stuff. Yeah,
absolutely. I mean, ARFID is obviously bodied in with a group of eating disorders, but it's different. It's got a different purpose, again, to things like anorexia nervosa, bulimia nervosa, binge eating disorder. ARFID stems from it's almost like a physiological lens of where they definitely have more of a medical problem with eating, whether it's sensory-based, whether it's physiologically based. They might have issues with their throat. And it's a textual thing as well with certain foods. So it presents like an eating disorder, and sometimes, as I mentioned a little bit earlier, almost autistic sort of lane there where it's just very refusal to eat certain things, certain flavors, certain types of foods. And they're very forceful in their mannerism of that. They will not eat what they will not eat. And so using sort of outdated approaches as well with ARFID kids is hard because they also sit with a difference of this isn't about being thin for them. This is really like I am terrified to eat that food. There is something in my body, in my mind that tells me that is really unsafe to engage in right now. They really don't want to digest it. Sometimes they don't even want to hold it. So using, again, an approach of what we do in therapy sometimes just doesn't really hit them in the same way. We've got to be almost extra compassionate with these kids in sort of what they're doing. I'm saying kids here, but it can be adults too. There are a lot of adults, I don't want to reference it just to be children because there are a lot of adults actually that are battling with ARFID too and getting misdiagnosed with other sort of diagnoses that appear like it but are not. Yes. So that's kind of how I would present it mostly. It gives a similar purpose. Absolutely, they can lose weight from it. There's the rigidity that's similar to OCD in it and autism, but it's got a different function, different purpose.
So how do you work with clients who present with ARFID?
Yeah.
Is it sort of the same framework or different?
Well, interestingly, I would use more of an ERP framework for ARFID than I would traditionally for anorexia nervosa per se. ARFID, I feel in my clinical experience, respond very well to ERP. Again, it may need to be a little bit gentler. It might need to be a little bit slower than what you traditionally would use with OCD, but it works well. It's about, again, with ARFID, we're exposing them to something and we're trying to help them learn that this thing that your mind and body is terrified of is actually not there to harm you, you know, and we might need to work with a dietitian in this sometimes. I mean, it really works nicely to have a dietitian, psychologist, parent, if it is a child. If it's not a child, no parent, you know, in on this. But I think that kind of really nice supportive layer around them helps with the ERP. But often my first lane would be, okay, again, education. Let's have a look at this thing that you are so terrified of, you know, and done it. I want to really validate them in that. I don't want to sit in front of them, but that's stupid. Like, why on earth wouldn't you be able to eat a banana? Like, how stupid is that? No, like, we want to really validate them in saying, I get it. That banana is super scary. You know, like, look at this banana. Like, is it the shape of the banana? I can think the shape's a bit weird, isn't it? Talk to me about that. Is it the fillet? What is it? And they give me all this juicy kind of content around why the banana is so terrifying. Then I sort of sit with them and go, okay, can we talk about that? I give you all this information about bananas. And I would go wild and crazy. I'd bring in videos about bananas. I'd show them all the healthy things about bananas, all the things bananas can do, good and bad. I put little faces on them, and whatever it is I can do to take away the fear, I'm going to give to this child. I'll learn about the child too. If they like Minecraft, I'll draw a banana in Minecraft. Whatever I can do to connect with them, I'm going to do. Then I'm like, okay, now we know that the banana's not scary. How about we go about this together one by one? And so sometimes what I'll do is I'm like, okay, I'm going to just draw a banana. Like, here's a banana. I printed it out. All I want you to do is hold this banana up. Can we just look at this together? We'll do it together. So we'll stare at this banana together. That would be my step one. That's my step one in ERP. Right?
Yeah.
Step two for me would be, okay, now all we're going to is we're going to watch like a video of banana, but we've got to keep our eyes on the video. So we're going to stare at the banana like for 3 minutes. And so we'll do that together. That could be step two. Step three could be we're going to draw bananas together. We're going to draw bananas together. We're going to do all this banana stuff together. Step four might be, okay, today, we're going to eat the banana. We're just going to hold the banana. We're just going to have contact with the banana. We're just going to do that. Today might just be for a minute. It could be less. It could be 10 seconds, whatever they can tolerate. And then we build. And so that particular step there, we're just holding the banana. That could be 3 steps. That could be today we're going to hold it for 30 seconds. Next week we're going to hold it for 2 minutes. The week after that, we're going to have the whole session. We're just going to hold a banana the whole session. Did it hurt us? Oh my God, it didn't. It's your friend. You know, love that for you. We can even give him a name, you know. Let's call him Henry the Banana. You know, whatever we can do, you know, take him home. Let's put Henry in a little bed, like really get that comfortability with a banana. Anything I can do to take that, I'm doing wild.
Yeah.
Yes. The next one will be, okay, now we've got the dietitian here. Now we know Henry the Banana's your friend. He loves your body. Like, he loves your belly. Like, the things that Henry the Banana can do in your belly. And we'll talk about all those amazing things he can do in the belly. And I'm like, I wonder if you could just lick Henry the Banana. So the first one would be just licking. We're going to accomplish that. Oh, how's your tongue? I'll get him to poke their tongue out. I'm like, your tongue is still there. I can see your tongue is still there. I love your tongue. Lift it up, lift it down. Like, yep, my tongue's fine. Are you okay? Yeah. So they do that. The very next one would be, let's just, okay, today we're going to a bite. And I don't know how long, this might take a long time to get them there, may I add.
Yeah, of course.
Sometimes it's not linear. It might not be linear. It might be a bit curly. But at the very end, we're like, okay, today we're going to do that little bite. And that's gorgeous. I love that. Sort of seeing them take that little bite and realize in that moment, they're okay. They're actually okay. You don't have to love Henry the Banana in your belly, but he loves you. Yeah. So it's kind of that, you know, we're not forcing them to love bananas, but really acknowledging that they're safe in that. And they may never love bananas. That's okay. We don't have to love every food. But Henry's great in your belly and he didn't hurt you. That's the goal. So the very end, obviously.
Flexibility.
You know, grandiose win would be if they're like, oh, I love bananas. I love Henry the Bananas. But obviously they might still say to you, I don't like bananas. They're yucky, but that's okay. But I can eat them now if I have to. And I know they're not going to hurt.
I'll eat it if I need to.
I can be present at a table where bananas are being eaten.
Yeah, I can sit around.
I can sit on the kitchen bench.
Yeah.
While I get on with my day.
A very elaborate way that I would kind of go about ARFID, but something similar. Adults might look a bit different, but to be honest, I'd probably still be wild and draw pictures and get them to have Henry the Banana on their bedside too.
Whatever needs to work.
I agree. I think the humour, regardless of age, is one of the best ways.
Yeah.
Best ways to work with clients.
Yeah, definitely.
In this space. Yeah, absolutely.
Yeah. So refreshing. And I know, I don't want to speak for you, Tori, but one thing that resonates for me is just knowing that working in this way is where we need to be heading as a profession, you know, in terms across all presenting difficulties that people experience. Because sadly, I think too many times we hear people coming in and we're like the fifth therapist that they've seen. And look, we're not going to be everyone's cup of tea either. You know, sometimes they might find the energy in the room probably a bit too much. In our clinic, we talk about fizzy clinicians versus breezy clinicians.
I love that.
So
cool. What is it? Cool. We're a cool breeze, or we're
a cool breeze, or a fizzy can of Coke.
That's
depending on how much
fantastic.
energy you bring into the session. And so you just got to find your person. And sometimes it takes a little while, but I think too how that clinician works is equally important.
Yeah, actually, I was going to bring this up before, Alissa, because one of the things that we hear a lot is when someone is working with their client who was referred for OCD, but then eating disorders show up as either down the track or maybe even at intake. And what we tend to find is that a lot of practitioners, actually irrespective of experience, unless they've done a lot of work with clients with eating disorders before, have this very strong urge to refer on to someone with specialty with eating disorders. And we try to discourage that. I mean, look, work within parameters. If you've had no training.
Absolutely.
Okay, sure.
Yeah.
But what we try to encourage is the idea of you've got the rapport, you've got a relationship with this client, you're already working, you already know their story, you're already formulating, integrated into the work that you're doing.
You have the skill set.
Yeah.
You have the knowledge.
Yeah.
Try and stick with it.
Well, especially given the sort of the overlapping nature of the way that we
work,
approach OCD and eating disorders.
Yeah.
I think, but anyway, it's an anxiety. I don't know if it's an anxiety that you see or hear about in the clinicians that you supervise, or even perhaps the clients that come along to your clinic may have been referred on. I don't know. I'm not sure exactly what my question is, but
no, I think your question was very fair.
Yeah,
I think it's a very valid question. We see it a lot, don't we? Either I'm getting referrals from just scared clinicians. As soon as the wording sort of comes up, they want to quickly boot them out the door. And that comes again from that, you know, mindset of I want to do it all right. I don't know how I'm doing this. But I think what you said was beautiful. If you've already got the rapport, you've already won. That is already revolutionary.
Yeah.
You know, we need to hone in on that. Rapport is it. That's your greatest gift as a psychologist. Everything else is a bonus. So, you know, unless they're grossly malnourished and they're grossly medically unstabilized, you've already got it right there in front of you to help that person. You know, it's gently leaning in. You've got the skills. You've got all of that there as a psychologist. And quite frankly, it's not that much different with eating disorders. You're not really using this completely existential style of therapy that's different to what you would do with OCD or anything else.
Exactly.
It's not different.
It's
it kind of shouldn't be different in some ways. It should be tailored anyway. It should be every person you see should be tailored, should be integrated. You should be bringing bits from different therapies to make that person's story and treatment not standalone anyway. So to be honest, you're so right there. And it's sad when I hear stories of you've seen how many? Seven other psychologists and you're 16. Oh,
yeah, it's pretty brutal.
That breaks me. I'm like, and it comes from, a lot of younger psychologists are scared, but I like to probe it to them. And this is a gift to work with this group. Like, you know, the win, how rewarding it is when you see them come full circle. There is nothing like that. Like, don't shy away from that. Grow yourself. You're a psychologist. Never stop learning. Never stop growing. Keep yourself moving. Right? Never be stagnant, right? And if eating disorders is that lane for you to grow in, take it. You're going to make mistakes. It's okay to make mistakes. You know, that's another thing. Like, you can't do it perfectly.
We still do, even as seasoned clinicians. Like,
yes,
absolutely. We're all still learning. We need to.
Yes.
Yeah. I think the danger there of not leaning into fear and that uncertainty when you do feel that urge to want to refer on is sending a very unhelpful message to a client, which is you're too broken for me, or you're too hard, or this is too hard, or whatever else it is, and that client feeling rejected, shame, and God knows what else. Unworthy, yeah. And just confirming everything they're probably fearing about themselves. I think that's far more unhelpful and dangerous than knowing you've got the knowledge and the skill set and the rapport and learning yourself along the way.
Absolutely.
Yeah, right?
It is sad. I mean, and even more so than eating disorders, I work with BPD. So BPD and complex PTSD are my number one presentation that I see. And that just what you resonated then is honestly what I would hear every single time they step into my room for the first time. Yeah. They feel so invalidated, so unworthy. They have been told they're treatment resistant. They've been told this is it for you. You know, you're going to have this for life. Like the way they're treated is unprofound. It's awful. And so, and I know in that moment, you know, again, take all the therapies aside, whatever you want to use it. I know what my job is, and my job is to connect with that person and make them feel validated and make them feel worthy. And, you know, again, if you've got that rapport with someone that's had a lifetime of feeling the total opposite, you're already winning. You're already giving them something they've never had, you know?
Yeah. You're already providing that corrective experience.
That's right.
Yeah.
Final words of advice?
Yes.
For clinicians listening?
Final words for advice, please be unique. You know, please be brave enough to do what your heart and your mind tell you. Use the science, use your learning, but also be real. You know, be yourself and really learn about your clients in a way that they need. You know, try to evolve yourself in a way that's going to resonate. Master rapport, please. You know, that's the bit. And I think you can only master rapport if you are yourself authentically. If you're trying to be, you know, somebody else, if you're trying to mimic a book, if you're trying to watch a video of another psychologist and be them, you never come across your clients that way.
No. Or even using someone else's words to explain something.
Yes.
You know, just finding your own way of conveying information, creating handouts if you must, and all the rest of it, like making it your own.
Absolutely.
To then connect with your client. Yeah.
Agreed.
Yeah.
This has been so wonderful and refreshing. Thank you so much for your time, Alissa. We really appreciate it.
My pleasure. Today has been so juicy. It's been so, you know, I really loved speaking to you ladies. It's so refreshing to be with like-minded people. And thank you.
Definitely.
It's such a privilege to talk to you today.
Thank you so much, Alissa.
Thank you so much.
Thank you.